All right, so we are continuing. I don't know if you can hear him, but I am being joined by my fluffy cat. You can hear him purr, maybe. Yeah, let him hear you purr, Earl. There you go. All right, so let's go ahead and finish up our discussion of opioids by talking about how we treat opioid abuse. So, addiction is a biopsychosocial problem. It involves biological factors, psychological factors, and social and cultural factors. And so, if addiction is a biopsychosocial issue, treatments should also involve a biopsychosocial approach because drug use and addiction is often going to be a multifactored problem. And generally, the best kind of treatments will consider the psychological effects, the physiological effects, the biology, the psychological state of the individual, and environmental factors as well. All of these are going to play a role. Now, like alcohol abuse, detoxification is the first step. This will typically involve long acting opioids that will help reduce withdrawal symptoms to a manageable level that aren't really dangerous. So the dosage will be decreased over a period of a few days, and it will help reduce those symptoms to a level that is much more manageable. Methadone is a pretty common way to do this. Another example is clonidine. Clonidine is another possibility here. It works on norepinephrine receptors. In particular, it works on autoreceptors. And so, what this means is that this basically functions on the alpha 2 receptors, and it's an agonist. So, it's an agonist of the autoreceptors. Now, normally an agonist would mean that it enhances norepinephrine, but an autoreceptor works a little bit differently in this case. An autoreceptor can actually cut production of norepinephrine in this case. So autoreceptors can cut neurotransmitter production. And in this particular case, that is going to reduce norepinephrine in the locus coeruleus. Now, you'll notice that many of the withdrawal symptoms, things like high heart rate and high blood pressure and diarrhea and increased digestion, all of those things are due to norepinephrine basically being able to work to its fullest extent. So, if we want to make withdrawal symptoms more manageable, another thing that we can do is prevent norepinephrine from working in its full effect. So when we take something like clonidine, it's going to reduce norepinephrine in the locus coeruleus, and that's going to inhibit norepinephrine neurons. So generally, we tend to find that norepinephrine is inhibited by opioids, and during withdrawal, they increase their firing. By cutting by cutting norepinephrine production, you are reducing the withdrawal symptoms. So, this is another thing you can do. But clonidine doesn't relieve all of the symptoms of withdrawal. It's not just norepinephrine that is affected, and it also has its own side effects. Now, generally, we know that methadone is a very common treatment for addiction. In particular, we will often utilize methadone for maintenance. So the idea is that what you basically do if you're very strongly addicted to opioids, after detoxification, you substitute methadone for heroin over the long term. So generally, what we will find is that by taking methadone, we reduce withdrawal symptoms as we talked about. It also relieves those cravings because you're not in withdrawal, and it also does reduce those drug seeking behaviors. But because of this, taking methadone will actually free up energy for other things that you could be doing. Because when you're addicted, all you want is the drug. You're going to spend most of your time and your energy trying to get that drug or trying to deal with that drug. If you can take something like methadone, where those cravings and drug seeking are reduced, you can do other things. Additionally, because methadone is an opioid, you will develop a tolerance to it. Additionally, this also creates a cross tolerance with heroin, and that reduces the likelihood of relapsing. Now, the problem is Methadone is typically given orally, but if you grind it into a powder and inject it, it will produce a high, and as such, it has strong abusive potential if it's inappropriately used. So, generally, methadone maintenance has to be very highly regulated. One of the ways that you'll see this is with a methadone clinic. These people will come to a clinic once a day and they will have supervised oral administration. Generally, we find when you do an oral administration, there's not going to be a lot of euphoria, but it will reduce the craving because it's a low grade opioid compared to heroin. Additionally, because you have to take it orally, it reduces the conditioned rituals of injection. It also reduces the risk of disease through dirty needles. Another thing that you can do is you can utilize buprenorphine as another maintenance method. Its brand name is Buprenex. It's a partial agonist that has weaker effects and a longer duration than methadone. So whereas methadone has to be taken daily, Buprenex only has to be taken a few times a week. If we combine Buprenex with naloxone, we actually get something called Suboxone. So again, it can be used as a maintenance method, but because it's combined with naloxone, which is an antagonist, if it's actually crushed and injected, because naloxone is a pure antagonist, it is going to block all of those euphoric effects. Now, having said that, this works pretty well, but there's still great potential for abuse. Other things that you can do are treatments that generally use narcotic antagonists. You can take naltrexone or Trexin. In this case, this tends to have a longer duration of action than something like naloxone. You generally take that orally. There don't tend to be side effects. You can take nalmefene or Revex. It's very similar to naltrexone. Tends to be a little more potent and longer lasting. But the thing that you have to watch out for both of these is that they do not eliminate the cravings and they do not eliminate the drug seeking behavior. So, because of that, we tend to use these a little bit less. Now, I've mostly been mentioning pharmacological support. So, I've mostly been talking about the biological effects, but you should have a multidimensional approach. This will typically involve detoxification, getting the drug out of your system, getting the pharmacological supports that you need, whether that's a maintenance method or something else, as well as counseling. Now, what's really critical for counseling, we're not just talking about talk therapy. In this particular case, you are talking all about the addiction, and you have very strongly identified the different environmental cues that trigger your cravings. And based on that, you develop a behavioral response that will help you navigate those cues. It might mean removing yourself from those situations. Another thing that may potentially help is Narcotics Anonymous. So we're pretty much done with that. So on Thursday, I am going to talk some more about the psychomotor stimulants, including cocaine, the amphetamines, and their many derivatives, including bath salts. I'll see you then.